Welcome everyone to the July 17th, 2024 Enforcement and Compounding Committee meeting. My name is Maria Serpa, Chairperson of the committee. Before we convene, I'd like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing the law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. As I facilitate this meeting, I will announce when we are accepting public comment. I have advised the meeting moderator to allot 3 minutes to each individual providing comments. Throughout the meeting and at appropriate times, we will begin with public comments for individuals attending in person, followed by those individuals attending via WebEx. This approach is necessary to facilitate this meeting. Before we get started, I'd like to start with staff moderating the meeting to provide general instructions on the process for providing public comment via WebEx. David?
When it's time to give public comment, we will ask everyone to raise their hands, and we will call on people in the order requested. For dial-in users, that means dialing *3 to raise your hand, and for everyone else, there is a hand button at the bottom of your screen. For our mobile device users, you have 3 different screens and only one of them has a hand, so you may need to cycle through using the ellipses button. That's the ... at the bottom of your screen in order to find that hand button. As stated before, you'll be given 3 minutes to speak, and I'll give you a warning before your time expires. And everyone should see a clock appear on their screen. For those who have visual capabilities, for dial-in users, you'll have to just trust us on the time, or start a clock on your own side. And that's it, Madam Chair, back to you.
Great, thank you. I'd now like to take a roll call to establish a quorum. Renee Barker.
Good morning, licensee member present.
Good morning. Indira Cameron Banks. I don't see Indira. I don't know if she's going to be joining us later. Jeff Hughes is not going to be joining us today. Sung Oh.
Good morning. I'm here.
Good morning. Nicole Tebow.
Licensee member present.
Good morning. And myself. Just to check, with 2 members not being present, is that qualify for a quorum? Can we move ahead?
Yes, 4 members being present, you have a quorum.
Great, thank you. Good morning, Corinne. A quorum has been established, and I ask everyone participating today to be respectful of the work before the committee. We encourage participation by members of the public throughout our meetings at appropriate times. The committee respectfully requests that when comments are provided, they are done in a professional manner consistent with how the committee conducts its business. Before we move to the next agenda item, I'd like to remind committee members participating via WebEx to remain visible on camera throughout the open portion of today's meeting. Members, if you need to temporarily turn off your camera due to challenges with internal connectivity, please remember to announce the reason of your non-appearance when you turn off your camera. Finally, I'd like to ask staff to send a link to all board members when the live stream of the meeting is available. This will ensure that members that are interested have an opportunity to review this prior to our board meeting later next month. We have some really wonderful presentations today. Thank you. We'll move on to our first agenda item. Item number 2, public comment on items not on the agenda and agenda items for future meetings. I will now ask the moderator to open the line for individuals to provide an opportunity to provide public comment. If you are not required to identify yourself, but may do so. I would like to remind everyone that the committee cannot take action on these items except to decide whether to place an item on a future agenda. Members, following the public comments for this agenda item, I will ask you to comment on what, if any, items should be placed on a future agenda. As a reminder, this item is not intended for discussion, but rather an opportunity for us to request consideration of an item for future placement on the agenda at which time discussion will occur. I'm not sure, I don't think we have any public members in Sacramento, is that correct?
That is correct.
Okay, can you let us know when there are members in Sacramento? Otherwise, we'll just go directly to WebEx.
Happy to do so.
Thank you. Moderator, we're ready for public comment for individuals participating via WebEx.
All right, we are accepting public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand. And I should also mention we have a Q&A section that's available. If you type the word comment, we'll address you there as well. Our first request comes from Monty Godard, followed by Keith Yoshizuka. Hold on, Monty. We're sending you a request to unmute your microphone.
Guys hear me?
Yes, go ahead, please.
Okay, excellent. Good morning. My name is Monty Goddard. I'm a 45-year licensed California civil engineer. I advocate for my wife, who has been an intractable pain patient for 2.5 decades. My wife's once well-controlled pain has been undertreated for the last decade, destroying her quality of life and our so-called golden years. Tragically, this harm is directly attributable to our state and federal governments' mistargeted and spectacularly failed so-called war on the opioid epidemic. I am an increasingly bitter man. My public comment this morning is again related to the ongoing pharmacy shortages of controlled substances, which has been made much worse by the state attorney general's nationwide opioid settlement with the 3 major distributors of controlled substances, specifically the settlement's injunctive relief. In case you are not aware, subsequent to our last meeting, the American Medical Association, the American Pharmacists Association, the American Society of Health System Pharmacists, and the American Society of Addiction Medicine on May 10th sent a letter to the DEA, HHS, the White House Office of National Drug Control Policy, and SAMHSA, requesting relief from this latest harm to patients. Their letter, which by the way should have been sent to the state attorney generals, focuses on buprenorphine products. However, the supply chain harm highlighted therein is true for all controlled substances. I would like to share some snippets of the statements of fact in this letter. First one, our organizations are deeply concerned about reports from our members that patients have struggled to have prescriptions for buprenorphine products dispensed at pharmacies. Next, we have received multiple reports from physicians and pharmacy colleagues that distributors are delaying or suspending orders because of the National Opioid Settlement Agreement. Pharmacies have not increased orders because of fears by distributors and pharmacies of exceeding thresholds, which would trigger suspicious order reports and subject the pharmacy and distributor to increased DEA scrutiny. Next, as a result of the scrutiny and subsequent challenges with pharmacies obtaining sufficient stock, patients continue to face delays and denials, frustrating the nation's pharmacies and pharmacists. This was just a sampling from the letter. I'll be happy to provide the letter. In conclusion, while the nation's pharmacists and physicians are being frustrated, patients are being harmed. Please prioritize the agendizing of this injunction threshold issue. The Board of Pharmacy needs to brief Attorney General Bonta on this grave
10 seconds.
issue. Thank you for your time.
All right. Next, we're going to hear from Keith Yoshizuka, followed by Stephen Gray. Hold on, Keith. We're going to send you a request to unmute your microphone.
The California Society of Health System Pharmacists. For a future agenda item, I would like a discussion of the enforcement of, in light of AB 352, which is the Barr-Kahn Reproductive Privacy Act. In particular, a letter from the Attorney General's office to CVS pharmacies, reminding them of the confidentiality. So in California, there's been rather open allowance to divulge prescription information to law enforcement without a search warrant. I would like some clarity, and perhaps the board may wish to consult with the Attorney General's office for their take on it. But how much of it can the pharmacy release? And there are certain restrictions, particularly in the area of reproductive drugs. The one specifically identified in AB 352. And maybe is it just the information contained in the prescription, or nowadays, because pharmacists are more involved with the care of individuals, some of the information that might be on the patient profile that is not directly involved or tied to the prescription itself. So, we'd like some clarity on that. What information can be released to law enforcement without a search warrant? Thank you.
Thank you. And next, we're going to hear from Stephen Gray. Hold on just a moment, Stephen. We're sending you a request to unmute your microphone.
Just like you heard from Keith a few moments ago, I also think it is very important to put this on the agenda of a future meeting. The letter was from the Attorney General to CVS, and it basically says that you have to have a search warrant, and it even says you can't even give out the information pursuant to a subpoena. And this is longstanding obligation by pharmacists to open, quote, their files to, quote, any authorized officer of the law. That is in section 4080, 4081, 4332, and 4333, and recently was added regarding ads machines to 4116 and 4117. To give you a little bit of background, there have been pharmacies and PICs that have been arrested, put in handcuffs, hauled away, their pharmacies locked up when they refuse to let in a representative of the district attorney. One in a famous case in Napomo, it cost the pharmacy that was recently purchased by a young pharmacist, and all he said was, I need to check with my lawyer, and they arrested him for obstruction of justice. After weeks of the pharmacy being closed, which affected patients in the area, it cost him over $10,000 and finally got the case dismissed. There have been other cases where the Medical Board of California has gone out and said, I want to look at all the prescriptions right now of a particular physician they were investigating. Same thing would have occurred, but for the fact that it was jumped in and put off. So this is something very important, and it has been you can check with Josh Room, former Assistant Attorney General who represented the board. The board has always maintained that it had the right, and so any authorized officer of the law, very broadly interpreted, to go in and check inventory records without a search warrant, without a subpoena, without even patient permission when they're investigating possible divergence of drugs. So this really needs to be put on the enforcement committee meeting and expedited to the Board of Pharmacy, because we don't want some confusion and patients harmed with not access to their pharmacies, and pharmacists, of course. Thank you very much. And if you don't have a copy of the letter, I suggest we can send it to you, but it was from Attorney General Bonta to CVS regarding the bill. Thank you.
Thank you.
And that was our last request for public comment.
Thank you. Board members, before I bring this back to you, just as a reminder, the first comment is on a future agenda item. We will be discussing access to controlled substances and the acquisition process. So that will be coming up. In addition to that, members, do you have any other comments?
Hi, Maria. This is Nicole. Yes, I would like to add to a future agenda the topic that Stephen Gray and Keith Yoshizuka brought up about the law enforcement and what to do. It's very scary when you're in that situation as a pharmacist, and I think we should get this really sorted out so our pharmacists know what to do in the event that they're in that situation. It's also, we're here to protect the public and protect their health records, so we should have a very clear idea of what should be shared and what shouldn't. We're unfortunately in a really politicized time where reproductive rights and LGBTQ plus healthcare are in particular under attack, and I would hate for those to be used against our patients. So I would like to discuss further.
Thank you. Yeah, I think that reviewing specifically the bill and the letter would be very informational for our committee. So that would be AB 352 that was quoted, and then the letter from the AG's office to CVS, I think would be very interesting, and perhaps have one of our attorneys help us to understand the impact of those.
Chair Serpa, this is Corinne. Just to interject, I think that we just need to be careful in this area. It's one thing to be communicating general information, but we certainly do not want to get in the position of, providing legal advice as part of these meetings.
Yes, thank you. Yeah, so what we're looking for is just background information about the documents that were presented just to the bill, and then the public letter, just providing some education to our committee. Would that be okay, Corinne?
I think we'll take it under advisement.
Okay, we'll work on that. Thank you. Thank you, Nicole. Anybody else have any comments? Okay. I don't think we need to vote on adding to the agenda, do we?
No, thank you.
Okay. Oh, I'm sorry. I'm on the switched to the wrong page on my script. That's why it had a vote there. It confused me. Thank you. So moving on to agenda item 3, approval of draft minutes from the April 11th, 2024 committee meeting. Attachment 1 of the meeting materials is a copy of the draft minutes from the April meeting. Members, do you have any questions or comments on these minutes? I would also entertain a motion if you think such action is appropriate.
I move to approve the minutes.
Thank you, Dr. O.
I can second that. This is Renee Barker.
Thank you. With a motion on second, I would now like to open to public comment.
We are open for public comment on the meeting minutes. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of your screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. As a reminder to our mobile device users, if you're having trouble finding that hand button, you can hit the ellipses button, that's the ... and cycle through one of 3 pages to find that hand. You may also type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. Looking around, I see no request for public comment at this time.
Great, thank you. Members, I think we're ready to take a roll call vote for the approval of the draft minutes. Renee Barker?
Approve.
Is Indira Cameron Banks not here yet or not joining us? Okay.
She's not present at the time.
Okay, let us know if she does join. So I'll skip her and we'll skip Jeff from the future votes. Sung Oh.
Yes.
Nicole Thibault.
Yes.
And I vote yes, motion passes. Thank you. Item number 4 is presentation on the board's inspection program. Members, strategic objective 2.3 on the board's strategic plan calls for the completion of routine inspections of all licensed pharmacies at least every 4 years to proactively assess pharmacy operations and educate licensees. On an annual basis, the committee receives a presentation providing a summary information detailing accomplishments towards this objective. I took a quick video of the slides included in the meeting materials, and I would like to commend board staff for their significant efforts to meet our strategic goal. As a reminder to all, the strategic goal was established without any additional resources. I'd like to welcome Deputy Executive Officer Julie Ansel to provide us the annual presentation. Julie?
Hi, good morning. How is everybody? Thanks for the opportunity to present today on the progress of our inspections this last year. Hold on, I'm going to turn off my phone so that doesn't make us all crazy. Thank you. So I'm just going to jump right in. Slide number 2, please.
Hi, Ann and Julie. I'm sorry. Can we see you guys? Because we're just looking at an empty room. So I don't know if that's possible, but
To see us?
I think maybe if Julie would sit at the testimony table, we could see you.
oh, that's okay. You don't have
Yes.
to move. You
Yeah,
don't have
yeah,
to
yeah,
move.
no, it's no problem. Hold on one sec, okay? Just let me flip around.
Yeah, the camera in that room, I don't think is movable, son. That's why.
Okay. I thought they could get the other angle from the. Oh well, it's okay. I'm sorry. I'm sorry to be a pain. I was just coming from the room full of empty chairs.
Okay, you can see my body at the table now.
Thank you, Julie.
Thank
Yeah,
you.
no problem. Okay, here we go. All right, we're going to start off. I have somebody working my slides for me. We're going to start off with number 2. So why do we inspect? You know, it's all about consumer protection. Sometimes I think people focus on discipline as consumer protection. And that is absolutely one key component of consumer protection, but it isn't the only component. And to that end, our inspection program really provides a significant opportunity for us to educate as part of the process. In fact, the board has established a policy goal to inspect all pharmacies every 4 years. And these inspections, provide staff, our inspector staff, the opportunity to observe and evaluate for compliance. And it also provides opportunity for education to the licensing population. I want to take this opportunity as we start to remind everybody that the board has many tools to assist in helping licensees be prepared for when an inspector arrives at the pharmacy. Some of these include our Ask Inspector program. Licensees can call in, ask questions, ask compliance questions, email us. We have a webinar on our website, how to prepare for an inspection. We also have a brochure that can be printed from our website explaining the process about an inspection, as well as we have mailers here at the office that you can get that are printed in color, and we can provide that to any licensee. We also have our script newsletter. And finally, for me, we have the self-assessment, and that really is the ultimate tool for a pharmacist and the pharmacy. It's really the roadmap to compliance. So lots of tools in the toolbox to prepare. Slide number 3. So this slide shows some typical items that the inspector might review and observe when visiting a pharmacy. They're going to look for a consultation. Is consultation being provided to patients? Do they see the notice to consumer? Maybe look for name tags, overall professional interactions among staff. And in general terms, the inspectors are there to see, what's happening at the pharmacy, what's happening within the pharmacy. Next slide. So during the inspections, specific items are going to be reviewed. The inspectors will confirm for compliance with various aspects of pharmacy law. We're going to look for completion of the self-assessment, compliance with cures reporting, is the pharmacy enrolled in the subscriber alert system. Inspector will review policies and procedures, possibly review the pharmacy's current QA policy. Some of the items that we will review. Next slide. So continuing, what is inspected? The board's going to assess the physical state of the pharmacy and check in on items such as the will call area. How does it look? Is it organized? Is the protected health information? You know, you always have those little tags on the bags and what have you. You want to make sure that's all secure and can't be seen from the the counter and what have you. We're looking at the shelving in the pharmacy, looking for expiration dates, expired medications, possibly expired ingredients in the pharmacy or on the shelves. And just overall, what's the state of the pharmacy? Is it clean? Is it orderly? Is it organized? Is it cluttered? What is the state? What is the physical state of the pharmacy? Next slide. So I talked about earlier how inspections really do provide a great opportunity for education for our licensees, and the board during these inspections really welcomes questions from licensees during an inspection. And as part of all inspections, there's an expectation that the inspector is going to be helpful, providing standard educational information to licensees. Typically, inspectors will review. We kind of have like a top, a little bit of a list that we kind of have in our minds, our inspectors' minds, of the current educational topics that can be provided during an inspection. These topics can vary widely depending on what's going on, varying based on new laws, possible new regs that are being implemented, as well as trends in pharmacy practice. So, we do the basics, but also there's varied educational items that might be covered in an inspection, depending on, what year we inspect, what month we inspect, what's going on in the overall industry. Next slide. So now we're going to get into a little bit of the meat of the numbers. This is our 5-year history total of annual inspections that we completed. This past year, we completed 2,904 inspections. When we pull this data, it's kind of a lot of data for us to get our hands around. So this data is just through June 19th. We don't have those last 10 days, and we can provide that. But what you're seeing is we did conduct this last year, approximately 2,900 inspections. And if you take it's interesting, if you take these 5 years and do an average, we're averaging at this moment 2,900 inspections annually. We'll probably come out at the end of the year at about 3,000, maybe a little over 3,000, just depending on what we get back in from our data review for those last 10 days. Next. So here we get a little bit more granular, starting to break it down by visit types. Inspectors are prompted to inspect a pharmacy for a number of reasons. Might be inspecting for a routine inspection. We might be coming for a consumer complaint. Maybe the pharmacy is on probation. We need to get in and assess from that aspect. And we may be also in a pharmacy and hospital, are still compounding for a renewal inspection, those mandated inspections. And as you can see, the majority of the inspections are completed by our inspectors in pharmacies. It's our largest site licensing program. We have over 6,000 licensed pharmacies. And then we have sterile compounding comes in pretty close as our second highest type of pharmacy inspections. Again, that's a required mandated renewal inspections. And those accounting for, almost 30% of what the board inspects on an annual basis. And then this is just a continuation of what I was describing above in terms of the types of inspections, and then the total at the bottom of 2,904. This is showing some other license types that we inspect. This slide is basically showing the number of ads, the automated drug delivery systems that we've been inspecting over the last few years. That's definitely gone up since we started doing that licensing, that license type, and then a handful of other inspection types you can see that have been conducted. Again, this is just through June 19th, but the ads here are 279. So yes, we have been getting out there and doing those. Next. So when it comes to routines, I'm going to get a little bit more granular on those specific types. The board did create a policy goal a few years back, trying to conduct a routine inspection in every pharmacy once every 4 years. So this is showing that the board conducted 1,431 routines in fiscal year 23-24. That's approximately 24% of our licensed pharmacies. And of that 1,431 routine inspections, about 1,048 were actually true routine inspections. And when I say that, what does that mean? That means we're just there at the location for the purpose of the routine inspection. There are other types of inspections we do, and we may have a routine affiliated with the visit type, but those 1,048, we're just specifically assigning inspectors to go and do the routine for no other reason. And you can see underneath that, I have numbers of 59, 229, and 95. That totals 383. Those were routines that were conducted at a pharmacy for a probation visit. Again, we talked about that before, or complaint investigation, or possibly we're there for the compounding renewal. We're going to do that LSC, LSE, what have you. And then we're going to go to the pharmacy and do a whole other inspection, pharmacy routine on that part of the pharmacy. Next slide. So this slide just kind of documents the outcome of the routine inspections that we conducted this fiscal year. So out of that 1,431, how does it all break down and what were the outcomes? So of our true routine inspections, we had 1,048. Over half of those, 561 pharmacies at the end of those routine inspections, they didn't receive a violation. There was nothing that we specifically found that we thought needed to be, pointed out. Yes, there's always discussion, there's education, but there was nothing that we needed to document. And then 438 of those locations, we did issue corrections. 55 of those, we issued violation notices. So these numbers won't necessarily tally exactly, because when you're going into one pharmacy, it's possible that they may receive one correction, one violation. They may receive 2 corrections, 1 violation. It can be a combination of things. So just knowing that it's not going to be a 1-to-1 ratio. And then also on this slide, I'm documenting our complaint visits, right? We're there for a complaint, but we're also going to do a routine. So with these, about 40% of those routines, the outcome was that they received no violations. About another 40%, those 95 pharmacies did receive a correction. And then another 20% or 44 pharmacies were issued various violation notices. And again, it's not going to be, these numbers won't add up to 229 because one pharmacy may get multiple corrections and or multiple violations in one visit. I did want to point out to the side, and I apologize, that this had been updated originally from what was distributed materials online and to the members. There's a minor update in the number of pharmacies under the complaint visit types that had received no violation, corrections, and violations. So just if the documents you're looking at are numbers a little bit different, the one I have projected here on this slide are the accurate numbers. And I apologize if that was any confusion on that. Next. So just kind of continuing, now we're at a pharmacy and we're there either for a probation visit or we're there for a compounding visit. Did a routine as well, and then what's the outcome, right? So here we see in our probation visits, these are the folks that are, we're really monitoring to get them into compliance. We go in for the routine, and basically the bulk of them, we did not this year issue violations. You can see 83% of the probation visits were not issued violations. And then about 10 pharmacies received 17 corrections. And then going down to compounding, we're there for a compounding renewal over at the LSC, and we bop over to the pharmacy, we do a routine, and what are those outcomes like? 43% received no violations, 52% received some corrections, and then we had 5% receiving violation notices. Again, reminder, one inspection, one pharmacy, they may receive multiple corrections and or multiple violations during one inspection. Next slide, please. So this slide is kind of delineating what the top corrections are that we have found this last year during our routine inspections. Sometimes what we need to be mindful of is when you look at these violation types, it could be a spectrum within one violation type of law. In terms of areas of noncompliance. One violation code may be used for an array of noncompliance or like maybe a sort of a range of egregiousness from not super egregious to more egregious. And I can provide an example. If you go through these violations on this slide, the first one is operational standards and securities. And that just really does, there's a spectrum of behavior that can occur that creates this or elevates it to a correction or to a violation, right? So under standards and securities, it could be, oh, you know, you had a dirty sink, or, oh, there was some rust in the sink, or, oh, there's no sink at all, or no hot running water. Maybe there's dusty shelves, dirty shelves. Pharmacy is kind of unclean. That could be one end of the spectrum, right? That's something that can be dealt with and is not as egregious. But then also within that code, the CCR 1714, that would be a situation where if we had something more egregious like a rodent infestation, that would also come under 1714. So here we have the same violation, but yet the behavior really yields much different outcomes on a spectrum. And the potential for harm is clearly far higher between a dirty sink and a rodent infestation. So just a different impact on patients and on the pharmacy overall. So just wanted to point that out. But yeah, you can see the top 10s, self-assessment issues, the notice to consumer may have not been there, and duty consultation issues. And we'll talk about that in a second, actually, those consultation issues in a routine. Next slide. So these are violations. Sorry, the slide before was corrections, the top corrections. This one's top violation notices. Kind of the same information, right? And again, just being mindful of the spectrum of what we can see with one particular violation code, and that, you know, it's a different outcome across one violation code. Again, duty to consult is in there. We had some compounding violations that ended up on our top violation notices for this one. I think that's it for that. So as I had mentioned before, next slide is the duty to consult, right? So we've been very focused for quite some years now on the importance of consultation in pharmacy practice. And this slide reveals that across our routine inspections, we had 121 pharmacies issued that had issues with patient consultation within the inspection. And again, we're remembering it's a spectrum, and we can talk through that. So kind of at the lower end of, or the higher end of the spectrum, I'll start off with, is where, you know, there was consultation was really an issue, right? The patient was not receiving consultation. So we had 13 of 121 inspections of those routine inspections where the inspector actually witnessed that consultation was not provided to staff. They actually observed it, or they observed that a staff member was screening for consultation, possibly a clerk or a tech. So again, on the spectrum, that's the more egregious part of it in terms of behavior of what we see in terms of consultation issues. Next, we had 45 of the 121 inspections. We saw that the pharmacy was providing mail order or delivery, right? But they weren't providing that written notice of the right to consultation with the actual mailed or ordered prescription. So that being documented and that being pointed out to the facility was important, is very important. And then lastly, Again, spectrum less egregious, but still we need to get it right. 63 of 121 inspections were the notice of the right to consultation for those delivered medications. It was possibly missing an element, right? Within that notice, there's certain things that have to be in there. There needs to be a phone number, their hours, the hours of operation. There's a specific number of days of the week that that the location should be open. And here we found that in 63 instances, that notice itself did not fully comply with the regulation. There was something that was just kind of out of whack and out of compliance. So again, another opportunity to make sure we're getting that right and getting that information out to patients. 16, next slide. So here we're going to kind of boil it down and summarize what we've been able to accomplish here, provide you with a summary in this pie chart. This is showing that, you know, we've gotten to a place where almost 80% of the board's pharmacy population has received a routine inspection in the last 4 years. And that is actually up from 69% last year. Last year, we were able to say that we got into all pharmacies licensed in 4 years, 69% of the population. This year, we've gotten up to almost 80%. This does not include, just a caveat, new licenses, right? We issued 324 new licenses this year. That's not part of this calculation. But they will then be included, those newer licenses, in our routine inspections into the coming fiscal years for a routine into the program. Next slide. So this is a good slide too. I like this one. This shows the progress we really made in achieving the policy goal to get in there every 4 years. I'm focusing on the line second from the bottom where it says the percent inspected within 4 years. And showing the progress where 4 years ago, we were at 37%. We were only getting into each pharmacy every 4 years, about 30%, 7% of the population. And now that we have made this a goal, we've been really striving to work toward this for everybody for all these pharmacies to receive an inspections within 4 years. And we've proudly gotten up to 80%. So just great job on part of staff. And if you just see, just calculating, we've actually increased that number about 14% annually in the last 4 years, where, you know, every year we're just chipping away and getting out to more and more places to be able to say, yes, we are getting to our facilities every 4 years, our pharmacies, per the board's policy goal. Next slide. So this kind of brings it all together. This last slide shows the total licensees, total population, and when their last inspection was. We talked about that 80%, that 79.7%, where we know we've gotten there in the last 4 years. And then the next line is we have 11% of our pharmacy populations. We know we've been there in the last 5 to 10 years. Clearly, we need to work on those. Then another 3% who haven't had they've had an inspection, but it's been an inspection, it's an other type of inspection within the past 6 years. It wasn't necessarily a routine inspection, right? Maybe we went in on a complaint investigation, maybe it was a probation inspection, and we didn't focus to get there. We didn't work on the routine, and we've really tried to kind of shore that up, where if we're there for a complaint or a probation inspection or a sterile compounding inspection, and then it needs that routine now, we're really trying to focus on making sure we get that secondary, you know, that inspection in there on those locations. So that's kind of where we're lacking, is that 20%. 6% have been licensed less than 4 years and haven't received an inspection. So those are, again, definitely going to be our target this next fiscal year. And then 0.3% have never been inspected. That ends up being about 17 pharmacies. So again, that's going to be on our target list as we go into the next year. We're just going to continue to do what we're doing, focusing on those never inspected, focusing basically on that 20% that we haven't been there in the last 4 years, looking at the oldest license issuance date as well as the oldest inspection date. And then the goal is just to keep increasing that 80%. We'll see where we can get to it. But again, I just believe it's been really great progress for the inspectors in achieving the goal. And we're just going to keep trying to strive to get out there and conduct as many routines as possible on an annual basis. And that's it. I'm happy to answer any questions that anybody might have.
Thank you, Julie. This was a great and presentation, very informative. I'm pleased to see that there's progress being made to achieve our strategic objective, and note that every year we continue to make progress. I truly appreciate all the efforts of field staff that perform these inspections, and again, emphasize that you were able to do this without increasing the number of staff. Members, do you have any questions or comments for Julie?
Hi, Chair Serpa. I just want to say, same with you. Thanks to all the staff. Really appreciate making a improvement in this area, and thanks to all the staff and inspectors, and you, and Anne, and Janice for hard work. Thank you.
Thank you. I appreciate that.
This is Renee Becker. I think just again, another kudos. That's a lot of pharmacies, a lot of licenses, but it's, it is so important, as was mentioned, for consumer protection. So, thank you, everybody. That's a great, getting close to that, closing that, or meeting that goal, I should say. So that's, especially in 4 years, that's a huge, huge increase. Thank you.
Hi, this is Nicole. I just wanted to also thank you so much for the presentation. That was very helpful in understanding. One thing that jumped out at me, this is a comment, this is not a question, was the number of pharmacies. And that when we look from 2020 to this current fiscal year, we're down like over 400 pharmacies in the state. And that's even with us saying that there were 300 added just this last fiscal year. So we're definitely seeing that we're trending down, coming up on 10% over a 4-year period. And I know that this issues of pharmacies closing has come up, but that was very striking to me of how high that number was. So that's definitely something, I don't know if this is the right committee to do it, but something I'd love to get a little more information on. We're hearing more and more about pharmacy deserts and patients not having access. So that's something I just wanted to flag that I'd like to hear more about somewhere.
Okay, thank you for that.
Remember to unmute. I think we're ready for public comment. I'd like to remind everyone present that public comment is not meant to be a question and answer session, rather an opportunity to provide comments on the presentation. Julie, you're under no obligation to answer any of the questions. In addition, as a reminder, please refrain from making comments on specific individual inspections or investigations to avoid any ex parte communications. I think we have no one in Sacramento, so let's begin with WebEx. Moderator?
We are open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. You may also type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. And our first request comes from Stephen Gray. Hold on just a moment, please. We're going to send you a request to unmute your microphone. You'll be given 3 minutes to speak, and I'll give you a 10-second warning before your time expires. All right, Stephen, we're going to send you another request to unmute your microphone.
Can you hear me?
Yes, go ahead, please.
Thank you very much. Yeah, I have a comment regarding the, first of all, I also want to applaud the board at improving the goal towards every pharmacy every 4 years. And I think a lot of progress has been made. It would be interesting to see how the current number compares with before COVID. I noticed that the data was back to 19 and 20, and that was during COVID. But how are we comparing back to pre-COVID terms, but that might be interesting for the board members to understand. My other comment is on the duty to consult. I noticed the comment, and I think it's great that there were the notices that went out when there was a mail order about how to get in touch with the pharmacy or pharmacist in order to get a consultation. But one of the things I know that is a problem for some pharmacies is the requirement that they offer that telephone access 6 days a week when the pharmacy isn't even open 6 days a week. So you might want to include that for board information in the next report or earlier, how that is being accomplished or whether it's being accomplished. There are a lot of pharmacies that are only open 5 days a week that are in, for an example, medical buildings that are only open 5 days a week. And then the last comment is I agree that we need to know when we see the number of pharmacies decreasing, it's important to know why they're decreasing. And I think that's, I don't know how the board can get a hold of that information. We do know that during COVID, a lot of pharmacy owners that had been hanging on just retired. And that was one of the cause. There have been some pharmacies that have moved out of state, big mail order pharmacies and so forth. And there have been several supermarket pharmacies chains that have just decided to get out of the pharmacy business. They were using it as a one-stop shopping attraction or even a loss leader. And these don't necessarily reflect an increase in the pharmacy desert situation, whether it be urban or rural, but it would be important to have the why pharmacies close information if we're going to talk about those subjects. Thank you very much.
Thank you. And that appears to be our only request for public comment.
Thank you. Members, any additional comments before we move on to the next agenda item? Oh, Julie, before I let you go, thank you very much for your comments. I really appreciate that. The presentation again was very excellent, and once again reiterate our appreciation to all the inspectors and under your leadership to reach our goal. Members, any other comments? Great, thank you. Moving on, agenda item 5, presentation on the board's citation program. Consistent with strategic objective 2.2, on an annual basis, the committee receives a presentation on the citation and fine program that includes information on common violations. Generally, this information is shared during an annual presentation and is also included in the board's newsletter, providing education to licensees about the most common violations during which citations are issued. Today we have Ann Sodergren, our EO. Ann, the floor is yours.
Thank you. Good morning, everyone. So as I start the presentation today, I do just want to remind members and those that are watching that the board does have various tools that it can use to resolve investigations. So depending on the nature and severity of the violations, outcomes can range from education of the licensee to issuance of a letter of admonishment or the issuance of a citation, all of which are non-disciplinary outcomes. When the board does take disciplinary action, that is done through the provisions of the Administrative Procedures Act. So if we could go to that next slide, wanted to start with just kind of a reminder of how we find ourselves with an outcome of a citation. So the next two slides provide very high-level overview of the complaint process and the citation and fine process. And the information, I believe, is in the meeting material, so I won't go into a lot of detail. But if you can go to that next slide, please. Specifically here in the middle of it, it really talks about the citation process. So at the beginning of that, the top of that flow chart, right, there are those other case closure types, the case closures for non-jurisdictional, insufficient evidence, those kinds of things. Then you have on the other side of the chart, those disciplinary actions that I was referring to. It's kind of that middle box that we're kind of focusing our presentation on today, where it talks about citations and orders of abatement. So we can issue those citations. We can issue citations either with or without a fine, and we can include an order of abatement with them. In all of those instances, when we issue a citation, the individual is afforded appeal processes. And we'll be talking a little bit more about those appeal processes as we go through. But from a table setting, wanted to just make sure that everyone had like a basic understanding of how the process works. We conduct an investigation, we substantiate violations of pharmacy law, and then depending on the egregiousness of those violations, along with a number of additional factors, the board determines or staff determine what the appropriate outcome is. And then if there is, if it is determined that a citation is the appropriate outcome, that's kind of what we're going to be focusing on today, how we get there and what the data shows us specific to citations and fines. So if we can go to that next slide, please. This information is detailed in the chair report as well, but there's a number of sections of pharmacy law and its regulations that we rely upon and that really kind of define both the board's authority and its policy specific to issuing citations and fines. So I'm not going to go into a lot of detail because it's both, it's on the slide giving kind of Reader's Digest version, and we do have it in the meeting materials as well. Next slide, please. This slide really kind of focuses on our fine authority. And our fine authority does vary depending on the sections of the law under which we are relying upon to issue the citation. So you'll notice, for example, under 4126.5, we do have the authority to issue a $5,000 fine per occurrence. So like if it's, per invoice or something like that, if that is the evidence that we had to substantiate the violation. That stands in contrast to Business and Professions Code 125.9, where the board has a maximum authority to issue $5,000 per investigation, right? So that the outcomes can be very different in terms of monetary assessment. So next slide, please. So as we reflect back on the flow chart at the beginning of the presentation, you notice that board members themselves are not establishing and determining fines or whether or not a citation is the appropriate outcome. Rather, that is done at the staff level. So to convey then the board's policy direction to board staff in determining giving guidance and policy direction on the factors to consider when assessing a fine, the board has promulgated 1775.2. And so what is displayed on this slide are those factors that the board is saying to staff, hey, you need to consider all of these things when you are determining what an appropriate fine would be. So if we go to the next slide. So with the foundation of the citation and fine program kind of briefly covered, we're now going to transition to review of some of the data. So as I begin today, I want to note that the data reflected for fiscal year 23-24 throughout the presentation is data through June 19th of 2024. So all of the other fiscal years do contain full fiscal year data, but for the current year, fiscal year 23-24, it is not a full 12 months. I'm highlighting that because if you do some comparisons to the data here with the enforcement statistics that are included, I believe it's under a separate attachment under agenda item 7, the numbers are not totally going to match, and that's because this is not a full year data set. So given this, the numbers are not going to be the same. In this slide, for example, the number of citations that we issued for the full fiscal year is 844, but you'll notice that this slide indicates 777, and again, that's because not a full fiscal year. I do also, though, want to note that even if the data for fiscal year 23-24 did reflect the full year, 844 is a pretty big decrease from the number of citations that were issued in 1920. So want to let you know that at the staff level, we are in the process of taking a deeper dive into understanding some of the reasons for the decline, and we will be providing far more detail in the board's upcoming sunset report as we discuss the board citation and fine program. Although we haven't completed that deep dive, we think that there are a couple of contributing factors here. One, with the changes in USP and some of the transition occurring with some of the compounding, we're really focusing a lot on education of those new requirements, perhaps as opposed to maybe issuing, violations where appropriate. And I want to be like very clear that a lot of what I'm talking about are generalized statements, right? Don't take one sentence that I'm saying here and apply it across the board. I'm giving like very general information. Another area where we think that there might be a decline in the number of citations is with the changes in continuing education requirements, right? We're really focusing on education of the new requirements and the cultural competency and things. And whereas previously, if someone, had not completed CEs in a specific area, that may have resulted in some sort of a citation and fine. We're transitioning back to kind of an educational model as people become more familiar with and integrate in those new requirements of the law. But like I said, we will be taking a deeper dive, and when we release the draft report, we would anticipate that there'll be some additional context provided for members and those interested in reading the report. So the next slide shows by license type, the number of citations issued. And again, just want to highlight that fiscal year 23-24 is not a full year. So this is not an apples to apples comparison in terms of the data for each of the fiscal years, but you can see some of that trending that we anticipate down from both the pharmacy and pharmacist. You can see it in the sterile compounding as well, in part some of the contributing factors that we believe the data will support when we when we've taken that deeper dive. Next slide, please. So when we look at processing times, you will note that from 2019-20 to fiscal year 23-24, you will see a slight decrease in the investigation and issuance time that's reflected. So the time reflected here, those average days, represent from the time we receive a complaint till the time that the citation is issued. So overall, over the 5-year period, you'll notice a slight decrease. But if you look at our times this year versus the last 2 fiscal years, there has been an increase. We believe that this is in part because of some vacancies, both our chief of enforcement position as well as a supervising inspector position. You may recall at the April Enforcement and Compounding Committee meeting, we reported that there was an increase in supervising inspector review time. So now we're starting to see how that impacts then overall citation processing times. So as we reduce the review times, both at the supervising inspector and that second level review, I do believe that, next year, our numbers specific to citation processing times, as displayed on this slide, will show improvement as positions are filled. Next slide, please. So this slide highlights the use of the orders of abatement, and the provisions for the orders of abatement are included in section 1775.3 for those that are interested in reviewing it. So when compared to last year, there has been a slight decrease in the use of orders of abatement compared with last year. This is another area that we're going to be exploring in greater detail as part of the board's sunset report. Next slide. So generally speaking, orders of abatements tend to lend themselves better to individual licensees due to the nature of violations. For example, completing additional continuing education in an area when the contributing, it can be addressed through CE to address the contributing factor to the violation. However, there are some instances where an order of abatement may be included as part of a citation for a business. An example of that may be an order of abatement that requires the entity to update policies and procedures to be consistent with the law, retrain staff, those kinds of things. It is important to note that some abatements may have been ordered last year with compliance being achieved this year. So again, you can't do a straight comparison on some of our data because it might cross over fiscal years. Next slide. So this again talks a little bit more about the orders of abatements, the board's authority to issue them. In 2018, the board really emphasized the use of orders of abatements, and since that time, they have been used with greater frequency. This details out some of the types of orders of abatement that we may do. Next slide. And this provides some additional information about the types of CE that we may require as part of an order of abatement. It's pretty routine to require medication error reduction strategies, immunization training, if that's what the underlying cause was. Sometimes if it's related to controlled substances, we may require as part of an order of abatement that they complete the board's prescription drug abuse training. It's important to note that orders of abatements at times are mandated as part of the citation. Other times it is put forward as an option. They can either pay the fine and or have a reduced fine if they complete the order of abatement. Next slide, please. This again provides some examples of orders of abatement that have been used. Next slide. So although each case is different, the egregiousness of a violation in general terms, we have found that some lend themselves better to abatement options. And so this provides some examples of where the types of violations where we may be using an order of abatement. Next slide. So let's talk a little bit about that appeal process and then go reflecting back on the flow chart at the beginning. Once a citation is issued, the licensee absolutely has the opportunity to appeal the citation. They have two different avenues to appeal a citation. They can appeal it to an informal office conference and or they can do a formal appeal. So you are not exclusive to a single type, but you do need to request the types of appeals that you would like. So as the slide showed at the beginning of the presentation, formal citation appeals are resolved through the process established in the Administrative Procedures Act. Next slide. So when we look at citation appeal outcomes specific to office conferences, what the data does show is that there really is a value in licensees exercising their appeal rights. Office conferences do provide an opportunity for licensee participants to provide additional information that was maybe not secured through the investigation process, to present mitigation actions that they've taken to address the issue. And those types of things can lead to modifications of a citation. Sometimes it might be a dismissal of the citation, reduction to a letter of admonishment, or in some cases being upheld or the fine reduced. So as the data demonstrates, the office conference does impact the outcomes of citations that were issued. Next slide. Again, just a reminder, sorry, feeling like a broken record player at this point, that the data reflected is only through June 19, but the data on this slide represents citations that were issued under the board's authority pursuant to Business and Professions Code 4314 that we discussed earlier in the presentation. So these are generally those violations for which the maximum amount that the board can issue a fine is $5,000, and it's generally that this is the most routine types of citations that we issue and the one that people are most common for the board to be issuing under. Next slide. So a few years ago, Business and Professions Code 4317.5 was passed. And as part of that, it did increase the board's fine authority under certain circumstances. And these are generally for community chain pharmacies. So you'll notice in fiscal year 21-22, which was when the authority was new, there was only one, but you will see a gradual increase in the number of citations that we're issuing pursuant to that authority. Next slide. So what this slide shows is although the board has the authority to, under 4317.5A, issue a fine of up to $100,000, and in 4317.5B, a fine of up to $150,000. From a practical standpoint, the citations that are issued under those authorities are not resulting in those high fines generally. You'll see that the vast majority of citations that are issued under those two separate authorities fall within the $5,000 to $10,000 or the $10,000 to $15,000 citation and fine range. Next slide, please. So going back to that general cite and fine authority, this slide shows the number of citations that were completed or appealed under that authority. And moving on to the next slide. This shows the number of citations completed or appealed pursuant to where the citation was issued consistent with 4317.5. Want to just quickly highlight this withdrawn prior to office conference and just highlight a trend that we are seeing. A number of the citations that we are issuing pursuant to 4317.5, we are finding that a number of citations are originally being appealed to the office conference level, and then as the office conference approaches, those appeals are being withdrawn and the citations are just being contested to the Office of the Attorney General. Next slide. So when we look at the top violations, this first slide shows the top violations that result in the issuance of a citation and fine for a pharmacy. So the data on these next 3 slides include the top violations for all citations issued. Later slides will provide you with a subset of this related to those to the high fine authority. I also want to piggyback on Julie's presentation just a minute, where she provided an example about that spectrum related to operational standards and securities. And I don't want anybody to think, wait, Julie's presentation said that if you have that kind of a violation, you're issued a correction or a violation. Sometimes, right, that spectrum based on those criteria and the factors set out by the board, that is going to result in a citation, right? And so we sometimes receive, presentations about, the board is not consistent with how it applies the law. And I want to just like re-emphasize what Julie talked about that spectrum of the violation, because not every violation, although it might be the same violation of the law, the egregiousness of that is different, right? So Julie talked about, the dirty sink versus the rodent infestation. So when we hear sometimes, well, I had the violation of 1714 and so did pharmacy X, and I was referred to the AG's office, but they got a citation or they got a correction. That might be because of where they fell on that spectrum. So where you see the same types of corrections ordered and violations under the inspection presentation, you're going to see some carryover sometimes here as well. And that's because the nature of the facts in a specific case are different. And so we just need to the context kind of matters. So it's the individual outcome of the facts of a specific case that are going to determine what a case outcome is. Next slide. So this shows the number of, or the top violations for a pharmacist. And you'll notice medication errors is up there. The board is really going to be focusing a lot of efforts on medication error reduction. And so looking forward to, all of the efforts with that medication error reporting, and then anticipating that, we're going to be seeing some of these things drop off. Next slide, please. You'll notice that pharmacy technician top violations, as consistent with prior years, are all related to unprofessional conduct, generally related to substance use. Next slide. Taking a deeper dive into the duty to consult, this first slide talks about failure to provide patient consultation under 4314. So you're going to notice that in fiscal year 2021, the data was we issued 60 citations. However, in fiscal year 23-24, there was 28. So that looks like a pretty big decrease. But in fiscal year 2021, we did not have the authority to issue under 4317.5. So you will see there has been a decline in the number of citations issued for failure to consult, but not as big as this slide reveals. So if we can go to that next slide, you'll see that under our higher fine authority, we issued 20 citations in fiscal year 23-24. For violations either under, similar violations of pharmacies under common ownership and control, or as a result of the policies and procedures of that community chain pharmacy. So there is a reduction in the overall total, but not as big as the one slide shows, because we have to add those numbers together. Next slide, please. So this really shows the violations, the top violations under that resulted in the issuance of a citation under our higher fine authority, so 4317.5A. So you'll notice that the most frequent of those is regarding notification of a pharmacist in charge, followed by medication errors. But you'll notice that we've also provided the average fine amount. And again, that's really just to highlight that although we have the authority to issue fines at much higher levels, generally we are not going straight to that 100,000 or 150,000. Next slide, please. So where we have used the authority established in 4317.5B, and that's where I'm oversimplifying, but where it's related to the procedures, the policies and procedures of that community chain, you'll see that we've issued 10 for quota violations and then 2 for 733 violations. Next slide. So I hope that that provides you with the flavor. As I indicated at the beginning, this is, this is general information. We are going to be taking a deeper dive into what some of the trending is telling us, and we will be highlighting that as part of the sunset. We will also be taking some of this information that's included in here and including it in the next issue of the newsletter to help provide education to licensees. That's the end of my presentation. Thank you.
Thank you, Anne. Wonderful evaluation of the program. I appreciate that. Members, do you have any questions or comments for Anne? I can't see your hands, and so speak up if I missed you. If not, I'm going to wait for a second here. I'll go ahead to public comment.
Hey, Maria, it's Nicole. Just wanted to say thank you, Anne. That was super helpful. I did have one question. I noticed that relative to the fines assessed, the fines collected is generally a lot lower. Is some of that it's like happening in different years? Is that why some of the years are like closer and some of the years are farther apart?
So that can be explained in part based on that, Nicole. Also in part because through that appeal process, we have maybe reduced that fine. So it's a combination of both. There are times when we may give people a payment schedule to pay the fine and everything. So a couple of contributing factors.
That makes sense. Thank you, Anne.
Okay, we're ready for public comment. As a reminder, public comment is not a question and answer session, rather an opportunity to provide comments on the presentation. And in addition, as a reminder again, please refrain from making comments on any specific citations or investigations to avoid any ex parte communications. We will begin with public comment. I don't see anybody in Sacramento. I think we'll go ahead to public comment via WebEx.
We are open for public comment via WebEx on the presentation. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. You may also type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. And looks like our first comment comes from Chi Su. Hold on just a moment. We're going to send you a request to unmute your microphone.
Informative. I had a question. I know it's not a Q&A question. I think particularly on the medication error part, just wondering if it's for lack of report or is actually for having medication error occurring. That's all I have. Thank you.
Thank you. And next we're going to hear from Stephen Gray. Hold on just a moment. We're sending you a request to unmute your microphone.
Thank you again. First, excellent report. I think this is the best one I've ever seen from the board. It's really very helpful. I stress the importance of this for those of us that teach pharmacy students. This gives us a lot of information to share with pharmacy students. They're always very curious about this, and it's brand new to their life, and it's very helpful. I would like some more information on slide 24. there was a term used for citation that I hadn't seen before, which is a citation for misuse of pharmacy education or pharmacist education. Perhaps it would be helpful to the board members to understand with a couple of examples, hypothetical examples of what that would be. We haven't seen, or at least I haven't seen that information used before. Thank you.
Thank you. And those were all our requests for public comment.
Great, thank you. Members, bringing this back for a final opportunity. Do you have any comments for Anne? Okay, I can't see your hands, but I don't think I see any or hear any. Thank you, Anne, again for the excellent presentation. I appreciate that. We've been meeting for a little bit here, so I think it's a good opportunity to take a 15-minute break. So we'll come back at 10:35. 10:35. Thank you. Okay, I think if everyone is back, you could turn on your cameras. Great, thank you. Okay, it's 10:35. We'll go ahead and restart. Thank you, everyone. Let me take a roll call. Renee Barker.
Present.
Sung Oh.
Present.
Nicole Tebow.
Present.
And I'm here also. Thank you. Move on to next agenda item, number 6, presentation on quality assurance reports received pursuant to California Code of Regulations, Title 16, Section 1711F, related to the use of automated drug delivery systems. Ooh, look at the nice picture. That's nice. Members, as detailed in the meeting materials, the board is required to submit a report to the legislature on the regulation of automated drug delivery systems, or ADDS, as a part of our upcoming sunset evaluation process. You may recall that during our July 2023 committee meeting, we received the first presentation related to the findings of the QA reports received. At that time, I expressed some concern about what appeared to be a lack of compliance with reporting requirements. Based on my review of the presentation slides today, that issue appears to have at least in part been addressed. Thank you to everyone who have submitted their reports and to the staff who are performing additional education about the mandatory recording requirements. I welcome Janice Dang, Supervising Inspector, to provide the presentation on the data received through these reports. And I believe Janice is joining us via WebEx. Is that correct? Hello? So let's see, is Janice available, or is she coming via WebEx? I see Janice as one of the participants, but I don't think maybe she's not able to mute. I'm not sure if her camera was tested. David, do you see Janice?
Yes, yes, I do. Hold on just a moment.
Okay, can you hear me?
Hi, Dr. Dang, we can hear you. Can we see you?
I have my camera on.
I think that's okay. We can see your slides. Members, is it okay if she continues with her slides? Corinne, is that an issue?
I have the camera on. I'm not sure why it's not showing.
I just wanted to check with Corinne to see if we have to see you. I don't think so because you're not a board member. But we have your slides and we can hear you. Can we proceed, Corinne or Anne?
This is Anne. Can you hear me?
Yes.
I apologize. I think our room was muted, so apologize. We've been very busy trying to answer all of your questions and we're unable to do so. So you are welcome to proceed. Janice does not need to be on camera to proceed with the presentation.
Great. Okay, thank you. Dr. Dang, the floor is yours.
Good morning. I'm Janice Dang. I'm a supervising inspector for the compliance team, and I also oversee the 2 inspectors that do the pre-license inspections of the 8 automated drug dispensing systems. Next slide, please. Okay. Before I go into the data that was submitted from the quality assurance reports for the med errors related to the ADDSs, I'm just going to do a quick review of what are the automated drug delivery system. So Business and Professions Code 4017.3 defines what is an automated drug delivery system, or what we call an ADDS. And this can be any type of mechanical system, whether you can find it inside a pharmacy that's being used to assist in the dispensing process, or it could be used at the hospital, at the nursing station, for the nurse to administer the drugs, as well as for these devices that are in doctor's offices or clinics where the pharmacy is dispensing the drug remotely through the use of the automated patient dispensing system. So throughout the the presentation, I will be referring these types of systems as an ADDS if it's in general, as a AUDS if it's a dispensing system where it is containing unit dose drugs that are being used for administration, and the term APDS for those devices that are being used as a dispensing device to dispense the drug directly to the patient. And with the APDS, one of the requirements is that when it is dispensing to the patient, if it is a new drug, or if it's a new prescription, or if the patient has any questions, it must have the capability of an audio video 2-way communication system integrated into the APDS. Next slide, please. Okay, so where do we find these? And I kind of gave you a brief description. Business and Professions Code 4427.2a requires any pharmacy that is operating an ADDS to license that device with the board. And so where you can find these is an ADDS could be located adjacent to the pharmacy. And that's, usually they'll use it for refills, and they could also use it for new prescription. What we've been seeing is they're mainly being used for refills, for patients to pick up their medication so they don't have to stand in line. And it's convenient in the sense that when the pharmacies close, whether it's on the weekends or after hours, that the patient can still have access to pick up their medication. Health and Safety Code 1250, healthcare facilities. These are facilities primary that are licensed by the California Department of Public Health, licensing and certification. So these are your acute care hospitals, your acute care psychiatric hospitals, your long-term care facilities. They can be found in primary clinics as well as specialty clinics. Health and Safety Code 1204 are specifically primary clinics that are psychiatric related. It can be also in clinics that the board license under Business and Professions Code 4180 and 4190. 4180 are your nonprofit and free clinics, whereas your 4190 type of clinics are your surgical clinics. It is in California, you'll find them in all the correctional clinics or all the prisons. Correctional clinics are unique to prisons, not jails. So in order for a prison to install an ADDS, they need to obtain a correctional clinic license first, and then they are able to install or operate an ADDS. And again, it requires it to be licensed. As I mentioned earlier, you'll find the APDSs in doctor's offices, and other locations where patients are regularly seen for the purpose of diagnosis and treatments. This is like your urgent care clinics, where the patients see the doctor and then they may have a APDS in their lobby, where the patients can get their prescriptions filled immediately after seeing the doctor. A licensed facility with statutory authority. So when the ADDS requirement for licensure first went into effect, it took into consideration most of the healthcare facilities that were licensed by CDPH. However, we found out there was a lot more other type of licensed facilities that had statutory authority to have a pharmaceutical supply of drugs at the nursing stations. And so new regulations went into effect to include those facilities. And these are primary facilities that were licensed under the Department of Healthcare Services. And the ones that we are seeing that are being requesting for licensure are those that are located in a psychiatric health facility and crisis stabilization units. And those are the CSUs are generally facilities where a patient may have a psychiatric crisis where they need to stabilize them before they send them to a psychiatric health facility. We also are licensing ADDSs in jails, youth detentions, and other correctional facilities. These are generally correctional facilities that are operated by the city or the county. So they are not required to be licensed as a correctional clinic prior to installing an ADDS. And then also locations of a cover entity, which is clinics or physicians that may have contracts with the federal government to provide 340B drugs. Next slide, please. So in addition to 4427.2, the locations that I mentioned that require licensure, there are a few exceptions that licensure is not required, but they are required to comply with all other requirements of the ADDSs. So those locations are licensed hospital pharmacies that are using it strictly for administration, where they own the drugs and they own and lease the ADDS or the device. And that it needs to be within a secure licensed premise area of the pharmacy. Or it could be within the secure licensed premise of a pharmacy. So under 4427.2I, hospital pharmacies, and what we've been interpreting is if you have a general acute care hospital license and there's approved services listed on the GAC license, they are included as part of the acute care hospital license. And so we will allow them to operate ads at the acute care hospital as well as anything else listed on their general acute care license issued by the CDPH. And so one of the requirements is that it has to be used for administration. If they are using it for dispensing, so what we are seeing is in the emergency room where the AUDS, they're using it for both administration and dispensing. If they're using it for dispensing, then we are requiring them to obtain a license, because the way the exemption is stated in the law is that it's only for administration only. So because they're using it for dispensing, we are now requiring them to be licensed. Pharmacies that are using an ADDS to assist them in the dispensing process, again, the law under Business and Professions Code 4427.2J, pharmacies are not required to license those ADDSs. And in addition, in the law, it does not state that they have to comply with all other requirements listed in 4427 at all. And so with the exception that and as we'll go forward, they are still required to submit quality assurance reports regarding the med errors related to the ADDSs. And then the other location where you will see an ADDS is listed under Business and Professions Code 4119.01. And this applies to the emergency medical system provider agencies, where they can either operate a pharmacy or a licensed wholesaler for the sole purposes of restocking an emergency medical supply ADDS located either at the provider agency or at any of these designated fire stations. And what they do is they will have the pharmacy or the wholesaler that is licensed as an EMS pharmacy or EMS wholesaler, and they will go to designated fire stations where they have an ADDS, and from that ADDS, they will restock the ADDS, and then the paramedics will access the EMS ADDS to restock either their paramedic truck or their emergency supply that's on the fire trucks and stuff. So that is pretty much where you'll see these ADDSs. Next slide, please. Okay, so Business and Professions Code 4427.8 requires the board, as part of its sunset evaluation process, to report any public safety concerns that's related to the ADDS. So as a result, we require that whether you are licensed or unlicensed, if a pharmacy is operating licensed or unlicensed ADDSs, that they are required to submit their quality assurance reports as it relates to medication errors through the use of the ADDS. Next slide, please.
Janice, this is Anne, and we cannot hear you right now. We lost your audio.
Oh, okay.
I can hear you, Janice. I'm not sure, maybe the room.
Is there a chat? Ooh.
Go ahead, Janice. We can hear you. I think there may be some audio problems maybe in the hearing room, but there's no public members there. Is that correct?
So do you want me to continue?
This is the moderator. I would encourage Janice to continue. We have a recording if the staff needs to review.
Okay, so next slide then. Okay, so Business and Professions Code 4427.7 requires a pharmacy to comply with the quality assurance requirements for pharmacies that are operating an ADDS. And California Code of Regulations 1711F specifies that whether you're a licensed pharmacist, whether you're operating a licensed ADDS or an unlicensed ADDS, that you're required to submit the report. So if you are a licensed ADDS, you're required to submit to the board within 30 days of completion of your review, your report. If you are a pharmacy operating an unlicensed ADDS, you must also report the quality assurance review report to the board annually when they're renewing their facility license. Next slide, please. So what is considered an ADDS med error? So the board does have on our website an FAQ that addresses the questions related to an ADDS med error, but this has been really one of the areas that our inspectors have been providing a lot of education to pharmacists as to what type of reports they need to submit to the board. And one of the big challenges that we have to explain to them is the difference between a dispensing error versus a nursing administration error. Because if you read Business and Professions Code 4427.4D, it states that the drugs that are stored in the ads is part of the pharmacy's inventory. And therefore, if the drug is dispensed from the ads, then it's considered dispensed by that pharmacy. So what we've been trying to educate these pharmacists and pharmacists in charge is that if you have an error, once it leaves the device, whether it was a stocking error or it was removed in error by the nurse, it is considered a dispensing error. Versus what if you remove a drug and it's for the right patient, right drug, but the nurse ends up giving it to the wrong patient, then that is considered a nursing administration error. So we've been having discussions one-on-one with the PICs, as well as I've been meeting with other, I've met with the CDCR, or the California Department of Corrections and Rehabilitations, to kind of give them an example of what they need to report versus what they don't need to report. So next slide, please. Okay, so the data that was collected that's going to be presented is from July 1st of 2023 to the end of April 2024. So it's not the full entire year, but it will give you an idea of where we are and the concerns that that are showing up as a result of these errors. Next slide, please. Okay, so to give you an idea of how many ADDSs are out there and how many we are licensing, this year we have a total of, as of March 2024, 1,149 licensed ADDSs. So these are, again, majority of all the ADDSs that we'll see these are all the ones that we actually have to do the physical inspections. These do not include the unlicensed ADDSs that are located in the pharmacies or in the hospitals. Okay. So this year you'll notice the difference between 2023 and 2024. 2022, 2023 was a little bit different. We had a few pharmacies that operate long-term care facilities that had a change of ownership. So when there's a change of ownership, all the ADDSs that were licensed under the previous owner has to be they need to submit a new application, and we require them to be re-inspected as well. So that's why there was like an increase in 2023 compared to what we're doing right now in 23-24. Next slide, please. Okay, so this, okay, so in, we have 3 different license types when it comes to ADDS. We have what I just went over, the first one, which is the ADD. Then we have the ADCs. The ADCs are the ADDSs that are operated by pharmacy at a clinic that is considered a covered entity, meaning they have contracts with the government to dispense the 340B drugs. So currently we only have one location that is operating an ADDS that is considered a covered entity. Next slide. And then the third type of license that we issue related to ADDS is your ADE. And these are your ADDSs that are operated by the emergency medical system. And so we, again, only have one location that is that's an EMS ADDS. Okay, next slide, please. Okay, so in just comparing where we're getting these reports from, so all of them are coming from those that are licensed and unlicensed as an ADD. So there was a total of 2,212 quality assurance or QA reports on med errors that were submitted to the board. And then of those, looking at what type of device they were either from an ADD that's located inside a pharmacy, Most of the reports we were getting were from the central fill pharmacies, the mail order pharmacies, and the long-term care pharmacies who are operating the ADDSs at the licensed premise, the pharmacy licensed premise. Then we had the AUDs are your ones that are, again, used for administration, and generally you see those type in the hospitals as well as in long-term care facilities, your psychiatric health facilities, your crisis stabilization units, where they're strictly using it for administration. We did not get any reports submitted by the APD facilities operating an APD. And one of the things that we are noticing is that in the beginning, when we first were licensing these APDS, there was there was an increase with these APDSs being placed into these medical offices, but we've seen a trend where they're discontinuing the APDS, and what they're finding out is, yes, it's great to have it at the doctor's office because the patient sees a doctor, gets their prescription filled right there in the lobby of the doctor's office, but then the patient continues getting the rest of their medications from their primary pharmacy that they go to. So some of these pharmacies that were operating these APDSs were not, it wasn't really as viable as they thought it could be, because once they were filling it at the doctor's office, then their model was to provide mail order dispensing to the patients. And a lot of these patients tend to, again, go back to their primary pharmacy to get their prescriptions filled. What we are seeing a trend also with these APDS is that some of these pharmacies are now putting it adjacent to the pharmacy for patients to pick up their medications, again, after hours when the pharmacy's closed, or if the line's too long and they don't want to wait in the line, that they can just go to these APDSs where they can get their prescriptions dispensed to them directly. Okay, next slide, please.
Janice, excuse me. I just want to stop here for a second. I think we need, if we could just pause for a minute or two to check the sound in the room. David, can you test the sound in the room to make sure that they can hear? And we can resume in just another 2 minutes. This is not a real break, just a technology check.
I have been checking with them via text, and they appear to be doing okay. It's up to them to unmute if they want.
Debbie, can you hear us in the room?
Hello? So Maria wants us to wrap this up.
Yes,
Hello,
we
I can hear you,
you.
Ann.
This is Julie.
Oh,
We can
okay.
hear you.
Okay.
Can you hear me?
Yes. Okay.
Great.
Okay. Oh, so continue. Okay, so this slide here compares the unlicensed, where the reports are coming from pharmacies that are operating unlicensed ADDS. There was 273 reports. Unlicensed hospitals that were operating unlicensed ads, we received 273 reports. Pharmacies operating unlicensed ads that are inside the pharmacy, we received 280 reports. And then all other ADDS that are licensed, we received 85 reports. Next slide, please. Okay, so this compared, just to give you an idea of the different pharmacy, where the reports are coming from. And I just want to say that, yes, we have seen actually a significant amount of increase in the number of reports being reported to the board. A lot of it was due to the efforts of our inspectors going out, calling the PICs when they're doing their pre-license inspections, notifying the PICs that they need to submit these reports. So pharmacies that are licensed as a PHY or PHE, we received 770 reports, which represents 25 pharmacies But again, we have a lot way to go because what the numbers in the parentheses is the number of total pharmacies that are licensed. So there's 6,135 pharmacies that are licensed with the board, and only 25 pharmacies who are operating ADDSs have reported quality assurance reports to the board. So this is kind of give you an idea of where we're at. Next, and then let's see. And what we saw like a really good effort is with the licensed correctional facilities. They made a really great effort in getting all their correctional facilities to submit their quality assurance report. So we did see a significant increase in the number of reports that they submit to the board. Okay, next slide, please. Okay, this here is again just where the locations of the ADDSs are and the reports that we're getting from. Again, the correctional facilities, they've been doing a really good effort, great effort in submitting those reports. So a lot of it was reported by the correctional facilities, and then the skilled nursing facilities, and then the pharmacies that are operating the ADDSs. And again, primarily those that we received from that were up with ADDS operating inside a pharmacy were those that were from the central fill pharmacies and the mail order pharmacies. Next slide, please. Okay, medications reported. Again, this is kind of like it breaks down the different types of errors that we are seeing. The ones that stand out are the wrong quantity as well as unauthorized dispensing. So this is kind of just a breakdown of the different types of errors that we're receiving. Next slide, please. And then this slide here kind of shows you, based on where the ADDS is located, is what type of med errors are occurring at each of those type of facilities. So, for example, in the pharmacy, the wrong quantity stands out, that majority of the errors are wrong quantity, where correctional facilities, their wrong quantity, wrong patient tends to be, the type of errors they're reporting. And then with the skilled nursing facilities and the hospitals, what stands out is the unauthorized dispensing. With the ADDSs, with those used in the skilled nursing and a hospital, a lot of them have an override function. And the purpose of that override function is in the event of an emergency that the nurse needs to remove a drug from the ADDS, that they could have the capability of removing and having access to that drug. However, what we're seeing is that there's like an overuse of that override button, causing unauthorized dispensing. Next slide, please. And then again, this is just a comparison of the type of errors being received. What stands out again is the ones inside a pharmacy is the wrong quantity. The ones that are using for an AUD, which is used for administration, it's kind of like all over the place. It's wrong drug, wrong strength, wrong quantity, wrong patient, as well as unauthorized dispensing. Next slide, please. And then this just compares where the errors occurred compared to if the ADS is licensed or unlicensed. Okay, next slide. Okay, data analysis. And so this is kind of what a review of all the QA reports. What we did was we looked at their reasons why the error occurred. And so this is the next slides are going to reflect that. Next slide, please. So we broke it down into four different locations. The errors being reported from inside a pharmacy versus at acute care hospital versus a long-term care or psychiatric facility. And then the fourth location is in a correctional clinic or jail. Next slide, please. So inside the pharmacy, what they usually have is there's various different types of ADDSs that they use. A lot of it will do the counting, the labeling, it'll take pictures, it'll weigh the product, the final product. So there's various different types that are used. Next slide, please. And so what we're seeing and what they're reporting is what's causing those errors, especially with the wrong quantity, has to do with, it could really be related to the size of the tablet or capsule. Some of these locations, especially the Central Fill or the mail order pharmacies, they weigh their final product, which is the vial, the drug, sometimes with or without the paperwork, and they compare it to what it should be. And so because the tablets are small or capsules are small or light, sometimes it does not detect that it may be a tablet or so off. Also, with some of these Central Fill and mail order pharmacies that they're reporting the error, could be related to when it's more than one container. So if you're dispensing 300 tablets and you're expecting to have 3 containers, not all 3 containers are getting grouped together and going out into one mailing package or to the pharmacy for the Central Fill. The other issues may be related to the cleaning of the device, where some of these devices, they have lenses which counts the tablets as they drop. And so based on the powder content of the tablet, they may need to do more cleaning or more frequent cleaning. We're also seeing that if it's a bubble card, that these are used in long-term care pharmacies where you may have misfill, where they may have 1 tablet or 2 tablets instead of 1 tablet in a bubble, or a bubble that's missing a tablet. And then with some of these devices that are more high tech, they have the capability of rejecting products as they are getting dispensed. And so if they fail to follow up on those that are rejected and they go through the system, they may result in a wrong quantity. Next slide, please. Wrong drug, contributing factors that they reported. It could be related to their workstation being cluttered. So not there, like I mentioned, there's all different types of ADDSs. Some of them where the device will count the tablet, but it doesn't label it. So then the technicians, when they're filling it, if they're dispensing or filling more than 1 prescription, their tabletop may be cluttered and they mix the label or and put the wrong label on the wrong container. Commingling of drugs could be related to, with some of these pharmacies, they really should only be putting stock bottles into the device where they can bar scan it. But what happens is some of the bar scanning process is not always done. So that could be related to the wrong drug, or when they're putting drugs, when they're restocking the ADDS, they're also putting in return to stock drugs also in there, which may cause also a wrong drug to go into the canisters. Next slide, please. Okay, in the Q Care, the second type of locations, the contributing factor, and this is like the most common one, was the unauthorized dispensing, where they're removing the drugs prior to the pharmacy reviewing it. So as a result, the override results in the wrong patient, or they override and they don't have an order, or they remove it for another patient because they know this patient has it, but they need to get it. So they remove it from one patient, knowing they're going to give it to a different patient. Next slide, please. Also, wrong drugs, contributing factors, including, again, not using they're failing to use the scan barcoding system. There's faulty drug identity check, wrong drug placed in the pocket, or when it's restocking, they place it in the wrong pocket, or they enter a formulation of a drug. This is when, say, for example, the pharmacy only stocks the ER or extended release dose in the ADDS, and the nurse doesn't realize it and takes it and cuts it in half because she needs half the dose. It's again removing the wrong formulation, and then wrong quantity is contributed to the nurse. A lot of it was related to waste, where they're taking 1 tablet out, but then when they're comparing it, what was administered, it's only a half a tablet was administered. And so the wasting of that tablet is not documented. Next slide, please. And then the third location is with your long-term care and your psychiatric health facility. Again, similar to your hospitals, where there's an overuse of the override button causing unauthorized dispensing. Next slide, please. Wrong drug, again, either the pharmacy processed the wrong drug, they packaged it with 2 different drugs, or the nurse removed the wrong drug because it was the wrong formulation, and then the strength as well. So they either processed the wrong strength, or they restocked the ads with the wrong strength into the pocket. Next slide, please. Okay, then wrong patient, contributing factors allow, this is when there's more than one profile for the same patient. Wrong quantity, again, is related to the nurse removing the wrong amount and not double checking what's remaining in the system, removing the wrong drug with a Schedule II controlled substance. One of the things that this was actually a concern, because when the nurse is removing, especially a Schedule II controlled substance, the Schedule II controlled substance in a nursing home, just because the nurse has an order, is not a legal prescription for the pharmacy. The pharmacy is still required to obtain a prescription from the doctor. And so as a result, if the pharmacy, if a nurse takes it and the pharmacist is not aware that the nurse removed the Schedule II controlled substance, there may be a problem with the pharmacy not getting the prescription prior to the dispensing. Okay, next slide, please. And then the last location was the correctional facilities. And the correctional facility is a very challenging because they are very unique. There's a lot of movement going between different prisons, between the yards, between the different, there's constant movement of inmates being moved throughout the jails. And so a lot of times the nurses may have the drug for one patient in this yard, but the patient moves to another yard. So then patient comes to the other yard and they don't have their medication, but there's another inmate that moved and that has the same med. So the nurse will, if she had removed and prepared all the doses prior to her med pass time, she may end up giving that dose to that new inmate that got relocated. So there was a lot of, because of their challenges, they spend a lot of time reconciling what was administered versus what was removed from the ADDS. And one of the contributing factors to that is because their system, the pharmacy system, is not integrated with the nursing administration system. So that's one of their contributing factors that causes a lot of these errors to be reported. So next slide, please. Let's see. Oh, I mentioned this. Next slide, please. Okay, and then so contributing factors for the wrong drugs, like I mentioned, inmates moving from different yards, inmates with similar names, medication removed using another inmate's name, wrong quantity, contributing factors related to duplicate removal by 2 different nurses. So the patient is in one, the inmate's in one yard, moves to another yard. The nurse already removed it from one device, and now the nurse is removing it again from a different device. So a lot of it, again, like I mentioned, is related to their challenges and the movement of these inmates. Next slide, please. Wrong drug, again, the use of the override button, which we're seeing, seems to be consistent with those where the nurse has direct access. So these are your AUDSs. And again, with wrong strength, removing the wrong strength, again, due to the override. Next slide, please. Okay, so these are just in conclusion, some additional comments, what we're doing. So we're continue educating pharmacies and pharmacists to increase the number of reports being submitted to the board. One of the areas that we're going to start focusing is we've reached out to most long-term care pharmacies. We've reached out to the correctional facilities. We're going to try to move, provide more educations to PICs that are in the hospitals, because we seem to have an underreporting from that location. What would help, and again, there's no law that requires it, is trying to standardize a reporting form. We're trying to encourage the PICs to evaluate why nurses are misusing the override button. And then we're going to start doing more inspections, random inspections of actual and follow up on these pre-license inspections. So once the devices are in operations, we're going to start going back out, look to see if the nurses are following the policies and procedures, as well as going into the pharmacies to see if they're following their policies and procedures as well. Next slide. And that's it. Thank you.
Great. Thank you, Dr. Dang, for the very comprehensive presentation and including the recommendations that you offered. I believe this information will provide a great framework for the legislative report. I'm hopeful that a draft of the legislative report will be available for our review at the committee's October 2024 meeting. Members, do you have any questions or comments for Dr. Dang? I can't see your hand, so speak up if not. Okay, similar to, I think we're ready for public comment. Similar to other presentations, just as a reminder, public comment is not a question and answer session, but an opportunity to provide comments on the presentation. I don't think there's anybody in Sacramento, so we'll go ahead and go for public comment via WebEx. David?
All right, we are open for public comment via WebEx. If you'd like to make a comment on the presentation, please raise a hand by tapping that hand button at the bottom of the screen. Dial in users, dial *3 to raise a hand. And you may also type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. Our first request comes from John Gray. Hold on, we're going to send you a request to unmute your microphone. You may need to dial *6 in order to unmute.
Hi there. Good morning. This is John Gray. I'm a registered pharmacist with Kaiser Permanente. Thanks very much for the presentation and for the opportunity to comment. Just a quick comment. With the passage of AB 1286 last year, we all know that medication errors in the outpatient pharmacy setting will be reported to the board. Additionally, the CDPH GACLS program requires hospital pharmacies to operate robust medication error reduction programs that CDPH audits too. Given these facts, in our view, once the required report has been made to the legislature, we believe that the requirement to report ADDS related medication errors to the board, which is in CCR 1711F, will be redundant. And therefore, we encourage the board to initiate a rulemaking to delete that requirement after it has made its required report to the legislature. Thanks very much for the opportunity to provide comment.
Thank you. And that was our only request for public comment.
Great, thank you. Members, any further comments? If not, Dr. Dang, I once again thank you for your time and for this really comprehensive report. I appreciate that. Moving on to agenda item 7, discussion on policy statement related to IV hydration clinics. Members, the meeting materials include relevant sections of federal law that establish the conditions under which compounded human drug products are exempt from 3 sections of the Federal Food, Drug, and Cosmetic Act. The meeting materials also provide some background information on the issue of IV hydration clinics, including information about warnings released by the FDA involving instances of drug products being compounded under insanitary conditions. The materials highlight that many warnings stem from compounding occurring at sites that are not regulated by the board, including IV hydration clinics. As we discussed during our April committee meeting, IV hydration clinics appear to be operating in a number of settings, including beauty salons, mobile vans, gymnasiums, and appear to lack appropriate oversight, use of appropriate equipment, and proper storage, and thus placing patients at risk. We also see examples of this practice in the media and advertising offering IV hydration in the workplace, home, or in hotels. These issues are occurring across the nation, including in California. As was shared during our last meeting, board staff have observed inspections in some IV hydration clinics and report witnessing alarming practices placing consumers at risk. Staff also report challenges with conducting investigations because even basic patient information, administration information, etc., is not maintained or provided to the board. Given the risk to patients and the documented harm, this issue was brought before our committee to consider the issue and determine if there are any actions that the board should take to protect patients. Following our discussion at the last meeting, we determined that the board should have a greater role in monitoring this practice and that we should start with the development of a policy statement to educate consumers about IV hydration clinics and some of the potential risks without creating undue concern for patients that have medication conditions that require such treatment. Attachment 5 to the meeting materials includes a draft policy statement. I note that the materials indicate that it is recommended that the approved statement include contact information for the various healing arts boards to aid consumers in understanding more about those programs as well. I reviewed the draft and believe it's appropriate. I believe it provides education and action steps consumers can take to protect themselves. As I open for committee discussion, I note that the meeting materials include a possible motion to recommend approval of the draft policy statement as presented or consistent with our discussion today. Members, do you have any questions or comments? I would also entertain a motion as a part of your comments if you believe that's appropriate.
Maria, this is Renee. Can you hear me okay?
Hi, Renee. Yep.
Hi. Yeah, thank you. Yeah, I think it's great getting this draft policy statement started, and I think it's pretty comprehensive. I did have a little bit of feedback, most of it for clarity, maybe. So just to see what the other members think. I know that we are referring to this as IV hydration clinics, but I'm wondering if we could have the opportunity to add an expansion, just like even a sentence that references what it's also known as in the general public, because somebody might, again, just thinking who's reading this, but they're also known as IV therapy clinics, med spas, IV nutrient therapy, vitamin infusion. So just so that people get a more full comprehension, because maybe people have heard of IV hydration for hangovers, but not maybe think it's different than when they go to a med spa or so just a suggestion for that.
I'm sorry,
My next
can you list a couple of names for IV hydration that you said something?
Yeah, when you kind of do a search, they kind of come up with IV therapy clinics.
Okay.
Med spa, IV nutrient therapy, and vitamin infusions.
Okay, go ahead and finish, and then we can comment. Thank you. I just wanted to write those down.
Yeah, I mean, the last two might be redundant, but that's kind of what I found with some names. And so the second one, I would recommend maybe that throughout the document, when the term mixtures is used, that we refer to it as IV mixtures. Because we do talk about IV hydration, and then we talk about putting additives into IV solutions, but then after that, it's just referred to as creating such mixtures, and then we refer to the mixtures. So I just think for consistency, we really are talking about IV mixtures. So again, up for discussion. And then there's also this, that what I just read, creating such mixtures is considered sterile compounding. Well, actually, the previous sentence, many of these clinics appear to offer patients a menu of pre-selected mixtures with various additives. And I just wonder if we can put examples, sometimes maybe the terminology. I mean, I certainly speak sterile compounding often, but I don't know. So if somebody says additives, just for clarity, perhaps adding a clause or something that says examples of additives such as vitamins, multivitamins, or electrolytes, or even just vitamins or electrolytes, etc. Like, I don't know, not to narrow it down, but I think giving an example that these are the additives that are being added to an IV solution.
Okay.
Okay, and then in the second paragraph, I'd kind of like to see where it says there may be very little evidence that these mixtures work. That it say that we add there may be very little or no evidence.
Okay.
Just for, again, clarification.
Mhm.
Also, there's a great sentence that's in that last paragraph. I guess, what is that? The third paragraph. That says, is it there? Yeah. IV hydration is, as the name implies, administered directly to the patient's bloodstream. And it goes thereby bypassing natural defenses can result in life-threatening reactions if administered in an unsafe manner. That whole two sentences, I guess. I think that is super key to getting the attention of, because this is kind of the whole reason that this is, threatening consumer protection. And if that could get added to the beginning of the first, maybe not in the first paragraph, but towards the beginning of the second paragraph, maybe even after the first sentence. I just, in my opinion, that is what we're, we want to just define the risk so that people continue maybe reading through the whole thing. So that's another suggestion. And then just the last, my last thought, and I don't know if we would do this, but, the FDA did have their, they issued a statement in 2021, called FDA highlights concerns with compounding of drug products by medical offices and clinics under insanitary conditions. And so then just maybe that's too much for this time, but it is directly from the FDA and does reference the risks, but also that, they'd like to see the states looking at this. So just adding that thought.
Well, those are all really great suggestions. I would hope that in the light of moving forward, that the members would consider including in their motion the opportunity to include suggestions made during our discussion, that I work with the EO in updating this to include our discussion so that we could review it and approve it as a board at our next board meeting in July 31st through the 1st. That way we're not wordsmithing it now, but I could work with staff and the EO to bring back something to the board meeting that includes your statements, and then also I'm sure Sung and Nicole might have other statements too. If someone wants to make that motion as a part of your discussion. Thank you. Any other comments from board members?
I'm happy to make a motion to, go ahead, Renee.
Okay, sorry. I was just going to say, then I would recommend approval of the draft policy statement, consistent with the discussion the committee's discussion.
And authorizing who?
Yeah, and authorizing the EO to make changes per the conversation.
Working with me.
Yes, working with the board president. Sorry.
With
the chair. With the chair.
I'm sorry, chair.
So Corinne, does that serve as a good motion?
Yes, that's sufficient.
Okay, so then
Thank you.
other board members, as you speak, give your comments, and if you think a second is appropriate, that would be helpful.
I second.
Thank you, Dr. O. Any comments? Any comments from Nicole?
No, Renee killed it.
I
Awesome.
know awesome. We have an awesome group here. Okay, I think we're ready for public comment via WebEx.
We are open for public comment on the motion. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. You may also type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. And as a reminder to our mobile device users, if you're having trouble finding that Q&A box or your hand, you may need to hit the ellipses button, that's the ... and cycle through your different pages. Our first comment comes from Stephen Gray. Hold on just a moment. We're going to send you a request to unmute your microphone. All right, Stephen, we're going to try again.
Thank you. It took a little while to come through. Sorry about that.
No worries.
My comments are, I think this is great, a great beginning. As I understand it, at the stage that it's at, it's going to be worked on by the executive officer, the chair of the board, and others to incorporate some of the comments, not the great comments that were made by Renee, and there may be other comments that come in, of course. One of the suggestions I would make is I think that the committee needs to be informed about anything that's going on with the medical board or the nursing board in relation to these facilities, these services, the problem that this is addressing. You know, I tried to find information from the medical board. Maybe they're working on a draft policy, the nursing board, but I think it's important for the committee and then the whole board of pharmacy to know what the other licensees, regulators are saying about the same subject. I think that from the tone, I know you don't want to cause panic, but I think it understates the seriousness of what could happen. You know, we only have to look at the New England tragedy, the New England sterile compounding tragedy, to realize that it only takes one or two or just a few places that are serving dozens and dozens of patients to have very serious consequences, even death, for some of these things. And they are growing. These services that are mentioned are growing quickly. And as was mentioned, they're even providing mobile services where they will come to wherever you are and and administer these products. And I've had several reports from people when we talk about this in professional that these are not being administered by nurses. They're not being compounded by pharmacies or physicians or anyone else who legally can compound them. So I think the statement is does not sufficiently warn the public about how serious this is. Thank you.
Thank you. And as a reminder, the draft policy statement, it will include the other the other healthcare boards that the board is working with on this statement. They will include their names and contact information. So the board is really interested in working with the other healthcare boards also. Thank you.
Thank you. Next, we're going to hear from Stacy Neroni. Hold on just a moment. We're going to send you a request to unmute your microphone.
Just put my question in the chat box. So I just wanted to know if you guys had considered or will be addressing all types of infusion. I know that there's a lot of sterile compounding pharmacies that dispense or prepare medication infusions and would like to infuse with employed RNs or home health agency RNs in the licensed pharmacy or just elsewhere in unrelated infusion clinics. And there's kind of a lack of licensure possibilities. Like no board has taken ownership of who or whether or not those facilities need to be licensed.
Thank you.
And that was our last request for public comment.
Great. Members, we have a motion on the table. Do you have any additional discussion before we vote? Okay. I'm not going to reread the motion. It's there giving what's on the screen, in addition to giving the EO and myself as chair of the committee the authority to update the policy statement consistent with the committee's discussion, and we'll bring it to the board meeting on July 31st, August 1st. Renee Barker.
Yes.
Sung Oh.
Yes.
Nicole Tebow.
Yes.
And I vote yes, motion passes. Thank you. Agenda item 8, discussion and consideration of updates to frequently asked questions related to Assembly Bill 1286. Members, as you may recall, that as part of our discussion on the implementation of AB 1286, given the comprehensive nature of this measure, we determined that the development of frequently asked questions was appropriate. The FAQs were initially approved during the February 2024 board meeting. At that time, it was noted that FAQs may need to be updated as additional questions were received. During our last meeting, we considered and approved updates. Before us today are additional updates for our consideration. Attachment 6 includes a copy of the updated FAQs, and as you will note, the new questions are questions number 8 and number 19. They are highlighted in yellow to make them easy to find. I thank the individuals who brought these questions forward to us. Such engagement ensures that the FAQs serve as an educational resource as intended. Members, I welcome your thoughts on the questions and would also entertain a motion for approval. Members?
Hi, Chair Serpa. This is Song. I'm just needing a little clarification since we have Anne, Julie, Janice, and Corinne on question 19. I am not really sure then how are we expecting them to actually do the transfer. I'm not following why it's a no. I can you just explain how that we got to there, and then how are we asking them to do it then?
So I think maybe Anne or Corinne, because it has to do with initiating a prescription transfer versus receiving a prescription transfer. Those are two different functions as I understand it. But legally, Anne or Corinne?
Yeah, this is Corinne. I mean, you just explained it. You know, I think it's the distinction between the tech initiating versus the tech receiving.
I think I'm not understanding it. So what are we talking about when we are initiating a prescription transfer? Are we talking about, because the law allows the pharmacy technicians to now receive prescription transfers, but we're not saying that they're not allowed to initiate receiving prescription transfers? I think that we need to just apply a real world scenario to just kind of explain what is that distinction, because I'm not following the distinction.
So I can jump in here. So I think that if the law or if the regulation is unclear, there's an opportunity to update the regulation, but the regulation says receive, right? So it's only about receiving it. So if you get a phone call, you can receive that information, but I can't initiate, as a technician, I can't initiate it. I can't go find that. And I think you may be correct. It's the regulation is not clear. But when the attorneys look at it, it's very clear that it's only receiving. And unfortunately, we've run into this unintended issue sometimes when our regulations are not as clear as they should be.
Okay, so Corinne, I'm sorry, I'm not trying to get into your legal advice or hypotheticals, but I think so. If I'm reading this, so okay, I'll just throw in hypothetical. So I'm a technician. I'm working in a pharmacy. I get a phone call. But that's not how it usually works. So in normal world of pharmacy workflow, a pharmacist who's going to fill the prescription is going to call the other pharmacy to get the prescription transferred. So are we saying that the pharmacist still has to call the other pharmacy to receive the prescription transfers, and that a technician are not allowed to call the other pharmacy to request a transfer? Is that the distinction? Because that's where I think it really would not, I don't think it'll live up to the intent of the legislation if that's where we're saying that's what it is.
President O, this is Corinne again. I mean, I guess my response to that would be looking at the words of the statute, and again, it says receive. And I think we have to go by what the statute says. So I understand, the real world example that you are setting out there. I guess my response would be yes, based on how the statute is currently worded. The tech is not allowed to make that first phone call. They can get the phone call in response, after the transfer has already been initiated.
Okay, I think we need to probably bring this up as a sunset issue then, because that's not, I don't think that this is a what overall regulated public was considering this to be. I think that there may be a disconnect between what happens in the real world out there of the prescription transfers and maybe the statute. So I think that it's probably best, it's okay, I'm okay to leave this question in there as per suggestion, but I think this may cause a lot more confusion than maybe what it's supposed to help. But
So President O, this is similar to another issue that we had that occurred in acute care. And maybe while we're discussing the unintended consequence of the legislation, we could remove question 19 and deal with the unintended consequence as a separate issue, like you mentioned in sunset. But I would be okay with removing question 19 so that we could further discuss it and not cause further confusion.
okay, that may be a better route. I'm okay with that as well, but I'll defer to other members because I think this is mainly community pharmacy oriented, and I would like some more, I guess, understanding and studying into this implication. So I'm okay to, I can make a motion also to move forward with striking out question 19 to do further evaluation of that question. But before that, I will leave if any other members have any other comments.
Not hearing any comments, but I think that part of that discussion regarding the statute and the telephone or what's the word, transfers of prescriptions. I think there's also going to be discussion in one of the committees regarding the authorization of technicians and how they are authorized by what training. So those two could probably be put together since it's the same part of the statute that would need to be looked at. So with that, would appreciate a motion.
I will continue with my motion. So recommend approval of the FAQs related to AB 1286. However, to strike out question 19 to further evaluate and research the statute 4115B1, and we'll have further discussion on that question on separate time, but we will move forward with the other FAQ that's highlighted, which is just question 8, I believe.
So just for staff clarification, is the suggested motion to approve the FAQs removing question 19? That's the motion, and then direction to staff to schedule or consider the best way to evaluate the provision to refine potentially the language of the statute? Or is that all included in the motion?
That sounds good to me, Anne. Thank you.
So I think what Anne is asking is that the first part be the motion and the second part be a direction, not part of the motion.
I really would like to make sure that this is done. So whatever way that you can make it work. So
it just means that when it goes to the board, 19 will be in there because we have to refer to it. Whereas if we strike it, then we would just take it to the board without 19.
That's probably a better option, Maria. Thanks for the clarification. Yeah, so let's strike out 19 as a motion.
And then direction to the board to evaluate question 19 to the statutory requirement. And does that help? We can't hear you.
So I think I believe where we are landing in the room here is the FAQs that are going to be sent to the board will not have question 19 in there because we are removing them pursuant to the motion. And then separate, and that's the motion. We're going to recommend approval. We will have question 19 removed separate from that motion. There's direction that staff will work to schedule discussion for the board to evaluate 4115.
Sounds good to me.
That sounds good. So it would be for the board. It would not be in this committee because it probably would have to go to a different committee. Okay. So I need a second, and we're ready for public comment or other board member comments.
This is Nicole. I'll second.
Okay. With a motion and second on the floor, we're ready for public discussion on the new FAQ, the new one. We're via WebEx.
We are open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. You may also type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. First, we're going to hear from Richard Dang, followed by John Gray. Hold on just a moment, Richard. We're going to send you a request to unmute your microphone.
Pharmacists Association, I just wanted to agree with President O's comments regarding question number 19 as well as his interpretation. So I appreciate the motion to remove that while you seek some clarification. And I think my next comment is maybe more of a rhetorical question on processes and probably for my own education understanding. 1286 was sponsored by the California Board of Pharmacy. So this is the group that provided the language to the lawmaker with the legislation. So I'm just curious as far as the interpretation of that language prior to the bill passing versus afterwards and why there appears to be a discrepancy. I would agree with President O's interpretation and the implications of the proposed answer to the FAQ question that was inserted in there. So further investigation and clarification would be appreciated to make sure that that is clarified to execute the full extent of the original legislation. Thank you.
Thank you.
All right. Next, we're going to hear from John Gray, followed by Stephen Gray. Hold on, John. We're going to send you a request to unmute your microphone.
Thank you very much. Good morning. This is John Gray, registered pharmacist with Kaiser Permanente. Thanks for the opportunity to comment again. Just, wanted to flag that if this issue around pharmacy technicians receiving a transfer becomes an issue that you want to address in sunset review. I believe it was President O no, sorry, it was Chair Serpa brought up the fact that there were some questions around the training elements required in 4115. And we did earlier this year provide some suggestions to the board in writing related to how you might want to tweak 4115 and the training requirements for cases where a pharmacy might choose to have a pharmacy technician being involved in, say, performing a transfer or taking a transfer, but not doing any of the tasks such as immunizing or administering epinephrine or collecting specimens for CLIA-waived tests. There might be some opportunity to tailor the training requirements such that they look different for someone who's, administering a vaccine as opposed to a technisian who the only additional kind of activity the pharmacy wants to leverage is being involved in transfers. So we did provide those written suggestions earlier this year. Happy to provide them again if it would be helpful. Thanks very much for the opportunity to comment.
Thank you.
And hold on, next we're going to hear from Stephen Gray, followed by NJ. Stephen, we're sending you a request to unmute your microphone.
Thank you very much. My first comment is on the new question number 8. This is a new, currently this is specifically addresses which, quote, which includes non-resident pharmacies. But the issue that has come up with that wording has been, does a non-resident pharmacy only need to report when there is a medication error that is sent to or for a California resident? You have non-resident pharmacies, for example, in Kansas that serve all 50 states and more. I'm sure they make some errors to those other states, but if it's the intent is to only require them to report them to the California designee reporting, receiving by the board, only when it's for a California person. So I think that needs to be clarified. On number 19, I agree with Sung Ho. It is not clear and needs to be addressed. The way we interpreted it when it was going through the legislature was that a pharmacist, a pharmacist has to be the one transmitting the prescription to a technician to receive it. So a technician cannot initiate, meaning they can't call another pharmacy and say, I want to send you a prescription, I want to transfer it. That has to be done by a pharmacist or an intern pharmacist. So I think that's what needs to be clarified. There was discussion that we didn't want technicians transmitting prescriptions to another pharmacy without a pharmacist at the home pharmacy knowing about it. The other thing that needs to be clarified is that this ability is only allowed by a technician for non-controlled substances. Federal law requires all transfers of controlled substance prescription to be pharmacist to pharmacist. So this should not mislead technicians to think that they can receive a controlled substance transfer of a prescription. Thank you.
Thank you.
All right, and next we're going to hear from NJ. Hold on just a moment. We're sending you a request to unmute your microphone.
To speak. As the previous members said before me, I just wanted to reiterate the question or comment about number 8, non-resident pharmacies. Do we need to report for non-California residents? Vice versa, if a California pharmacy has an out-of-state license, do they need to report errors for residents that are outside of California? I would assume that the Board of Pharmacy is just interested in California residents, but we just like that clarification. Thank you.
Thank you.
Thank you. And that was our last request for public comment.
Great, thank you. Hey, board members, we have a motion on the table, and that is to approve the FAQs, including number 8, not number 19. Any other comments before we go to the vote? Okay, Renee Barker,
Yes.
Sung Oh,
Yes.
Nicole Tebow,
Yes.
and I vote yes, motion passes. Thank you. Next agenda item 9, discussion and consideration of the committee's strategic objectives. As indicated in the meeting materials, the Enforcement and Compounding Committee has 10 strategic objectives. The meeting materials include updates on the objectives, highlighting our efforts over the past year. I'm very proud of what the committee has accomplished towards its strategic objectives and looking forward to this continued effort, including our activities related to reducing medication errors, which is the core to our consumer protection mandate. I'd like to also acknowledge the progress staff have made on meeting strategic objective 2.3. I believe we're making great strides to reach the 4-year benchmark. Currently, 79.7% of pharmacies have been inspected within the 4-year period. Also want to highlight that only 0.3% of all licensed pharmacies have never been inspected. I assume those facilities will be prioritized in the coming year, and I look forward to our continued pursuit of the strategic objective. I'd also like to highlight that our committee's work is completed in strategic objective 2.5, specifically related to the consideration of further use of a standard of care enforcement model with the submission of the legislative report. Work in this general area continues through the licensing committee. As you may recall, the licensing committee is considering provisions related to a more robust standard of care practice model for pharmacists. As we continue our work related to strategic objective 2.8, I believe it may be appropriate to focus some efforts on education of non-resident pharmacies. This would serve as a nice complement to the work being undertaken by the licensing committee related to the regulations of non-resident pharmacies. Our work related to strategic objective 2.10 resulted in the initiation of a formal rulemaking process to update the board's compounding regulations. I'm very proud of the work that we've completed as a committee and truly appreciate all the engagement we received from interested parties. We cannot discuss the regulations themselves today as they are not part of the agenda, but I look forward to discussing them during the July 31st and August 1st board meeting. Members, as I open for discussion, I would be interested not only in your comments to the current objectives, but also if you believe additional strategic objectives may be appropriate. I believe it may be appropriate to add a new strategic objective aimed at evaluating the barriers to patient consultation. Appropriate patient consultation could reduce medication errors and also improve patient understanding of medications, adherence, and safety, and address the challenges of low medication literacy rates. So as we're moving forward, I would welcome your thoughts on the strategic objectives and would appreciate a motion if you think a new strategic objective is appropriate or a change in the current strategic goal. As a reminder, the strategic goal for 2.5 is complete, but we don't need a motion to remove this goal. Members, you note the screen has my suggestion for the addition of a new goal, but I appreciate your comments on the current goals, the report, and if you have any new strategic goals that you'd like to discuss. Members?
Thank you, Chair Serpa. You've summarized the strategic goals very thoroughly. So just no other comments other than to kudos to staff and for everyone for working so hard on accomplishing these goals. And I totally support the new suggested new strategic goals that is suggested by you. I believe that it will be a great opportunity for us to understand the challenging nature of why that we may continue to come across the consultation issues. And I think there's a lot of areas that could be understood by this. And so I totally support, and I'm more than happy to make a motion to add strategic goal 2.11, I would imagine, enhance patient consultation compliance by evaluating barriers to consultation to provide patient education and reduce medication errors.
Thank you. Any other comments, or is there a second?
Well, I have a comment, but I will also second. I just wanted to say I know we're going to evaluate what the barriers are, but I think that down the line it might be good to work on this new strategic goal in conjunction with the Communication and Public Education Committee. I feel like, just off the top of my head as a pharmacist, one of the biggest barriers is patients just don't want to wait any longer. They're rushing. So to have that education to the patients about why it's so valuable and have it coming like kind of from both sides. So it's not just us trying, it's the patients wanting it as well, I think would be really helpful.
Good point. Thank you. Renee, anything to add?
No, nothing to add. Again, a lot of work's been done, so thank you, staff and everyone. So that's it.
Great, thank you. So I think we're ready for public comment via WebEx.
We are open for public comment. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand. And you may also type the word comment in the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. Our first request comes from Stephen Gray. Hold on just a moment. We're sending you a request to unmute your microphone.
Thank you again. First of all, I also want to congratulate the committee on working on these goals very diligently, and I think you've made substantial amount of progress. I support wholeheartedly the addition of a goal related to consultation. What happened during COVID was the phenomena that people want to stay home and get deliveries, or they don't want necessarily to come into the medical center. This is indicated by the use of the APDS and many other things. But one of the things that also happened was organizations, even organizations that believed in the value of prescription consultation, during COVID, didn't want necessarily people to come in that could be infected or could get infected. And so they initiated curbside service, just like Target, just like many other organizations. And so the net result was a lot fewer prescription consultations were initiated or given to patients, even in organizations that believed in their value. And so I think the whole topic needs to take another look at. I would encourage the board to also consider sponsoring a study on the value of prescription consultation. There's only been one study done in the United States of any significant value, and that is over 2 decades old and done by Kaiser Permanente, that did a $2 million 2-year study on the value of prescription consultation with oversight by the University of Southern California School of Pharmacy. That study proved that there were reductions in hospitalizations, emergency room visits, urgent care, and many, many other benefits from having a pharmacist give comprehensive, thorough consultation to the patients or the patient's agent as they were picking up the prescription. I think that that needs to be repeated and somehow the value of that coincide with what we tell the public and what we tell employers and what we tell other policymakers about the value of pharmacists giving prescription consultation. It's time to do that again and to do it with equal or better scientific rigor. Thank you.
Thank you.
And that was our only request for comment.
Okay, thank you. Members, do you have any additional comments before we go to the vote? Seeing none. Renee Barker?
Yes.
Sung Oh?
Yes.
Nicole Tebow?
Yes.
And I vote yes, motion passes. Next agenda item 10 is review and discussion of enforcement statistics. The meeting materials include a summary of the enforcement statistics for 2023-24, as well as a 3-year comparison. Board has initiated 3,183 complaints and closed 3,237 investigations. As of July 1st, 2024, the board has 1,662 field investigations pending. The materials provide a breakdown of the average time frame for the various stages of the field investigation process. I did note improvement in the average time for cases pending supervisor review and thank everyone who contributed to reducing that review time. Looking at the 3-year comparison data, I noticed that the board has realized a gain of 5% growth in investigations received, as well as an increase in the number of cases closed with insufficient evidence. Staff have advised that this is a trend in part explained by the increased consumer complaints received that are non-jurisdictional, such as customer service issues. Members, I welcome your thoughts on the enforcement statistics. Members? Seeing none, I think we're ready for public comment via WebEx.
We are once again open for public comment. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial in users dial *3 to raise your hand. And everyone else may type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the agenda?
Please, thank you. Thank you. Our last agenda item is 11, future meeting dates and adjournment. Before we adjourn today, I'd like to thank everyone for your time and participation. Our next meeting is scheduled for October 16th. And remember, we do have a full board meeting at the end of the month. Please monitor the board's website for updates. The meeting is adjourned. Thank you very much.
Thank you.
Thank you.
Thank you. Have a good day.